he has um, he has a vast experience in working with various government medical colleges and many other hospitals in Mumbai and in other places. And he is also a visiting fellow in epilepsy at Cleveland Clinic, USA. And he is a founder trustee of an organization called Forum for Indian Neurology Education, which organizes teaching courses in neurology. And he is a member of steering committee of ELICIT, that is end of life care. Sorry, Sripriya? Yeah. Somebody. Sripriya? Is there echo from my end?
No,
I
sir.
have not.
I believe Dr. Roop was trying to log in from 2 devices, most probably.
Okay.
So.
Okay, so he's one of the members of end of life care in India initiative task force. And you know that recently we had an order from Supreme Court regarding new directions on end of life care in India regarding withdrawal and withholding life support. And he is also an interdisciplinary task force member of Indian West and palliative care physicians as well as a neurologist for end of life care in India. He has helped us with many courses. So welcome, Dr. Roop, and it's over to you. You are not audible. Please unmute.
Yeah, now?
Yes, audible.
Okay. Yeah. So my problem is that my laptop camera has gone. So I'm going to actually work out of 2 devices. So anyway, I think I managed it finally.
Okay.
So, can I start by sharing my screen?
Yes.
Okay. Yeah, somebody will have to enable my screen share.
Anubar Sripriya?
Yes, sir, working on that. Anup, can we make Roop sir's the other
co-host,
device also co-host?
Yeah, not the one with the video, the one without the video.
Sure, sir. And I can see one is in complete caps and the other is, so I believe you want.
Yeah, otherwise I can manage, but.
You are now a host.
Yeah.
Yes,
sir. Thank you. Here it is. So, as always, it's a pleasure to be here with the Pallium India group and the large number of people who tune in to listen to and to learn from their experience. It's always a privilege to be part of this. So today I'm going to be speaking about end of life care. And if you notice the tagline, it's a citizen's perspective. It is not just a doctor's perspective. It is something that matters to all of us. And what I'm going to do is first spell out the objectives. The first objective is to explain prognostication at the end of life. How do you know that the end of life is reached? Discuss care of the actively dying and analyze the current medico-legal scenario, because as you are probably aware, things have changed fairly recently. And I'd like to begin by asking you to think about your own death. Remember that all of us don't want to think about it because we think that dying is dying with pain and suffering. And this has been said long ago by a comedian. I'm not afraid of death. I just don't want to be there when it happens. Part of the problem is that we study the quality of life. There are so many different situations in which this is discussed and thought about. But where do we actually look at the quality of death and dying? So what is quality of death? Quality of death is good life till the very end. And importantly, we have to measure and work on minimizing suffering. And you do this by understanding that at the end of life, too, patients have rights. Some boundaries need to be understood. Remember that actively dying, I'm going below upwards, is a very short period, days to hours. It's based on physiological parameters and it's usually irreversible. Terminal care is, I'll explain that a little further away, and so on, so end of life care. But remember that palliative care is applicable to all serious health related suffering, whether it be from diagnosis or right till the end. So end of life care in that sense is a slightly artificial distinction when you estimate that the time is, depending on the system that you're in, 6 months to 1 year. And especially in the US, once you say that somebody has a prognosis 6 months or less, then they're entitled to hospice care from the government. So one definition for terminal illness is one from which recovery cannot be expected with the available treatment, and death is considered to be unavoidable in the foreseeable future. So end of life care is the approach to a terminally ill patient that shifts the focus of care to symptom control, comfort, quality of life, and quality of dying, with support for the family. And treatments that are aimed at cure and or prolongation of life can then be stopped. This paper shows disease trajectories at the end of life, and we'll be discussing these a little further. Remember that these capture about 90% of the trajectories, but some can actually combine. So the first trajectory, which is not really a trajectory, is that of sudden death. Somebody is hale and hearty, and then they pass away. Now, actually speaking, before the age of 50 years, well, people do all kinds of risky things. They get involved in fights, they go to war, they become terrorists, they smoke too much. But after the age of 50 years, most of these risky behaviors have settled down, and then less than 50% of people, less than 10% of people die suddenly. Remember our long-haired president, he actually died suddenly at the age of 83 or 84. But the only thing I can say is that with all the punya that he had earned, well, he was entitled to that then. But for most of the rest of us, our deaths are going to occur after a certain predictable period of illness. Now, if you look at, if you saw sudden death, we looked at somebody who was functioning near normally. So again, even in cancer, as of now, which affects mainly people in their 60s, they maintain fairly high function until they've gone through their first chemotherapy and so on. But there is a point at which the tumor burden just crosses a point and is no longer amenable to any treatment. And here, this becomes a waterfall trajectory. It's very, very predictable because it's biological. It depends on the amount of tumor that you have, and that determines time of death. This accounts for about 20% of all deaths. And you can see, I'm sure you can recognize the VIP whose photograph is here, Mr. Manohar Parikar. Then the next pattern or trajectory of illness towards the end of life is that of organ failure. Now, organ failure typically affects people a little later, maybe a decade after malignancy. So in the 70s, these are people who have bad diabetes, hypertension, and who typically get kidney, heart, lung, liver failure. And this accounts for something under 20%, maybe close to 15% of all deaths. And because these patients have crisis, they don't recover as well, then again a crisis in hospital, then again not so well. Eventually they probably pass away during crisis. This is called the looping or entry-re-entry trajectory. No VIP here. VIPs get transplants. It's a common man who has this kind of a death. And then look at this. This is somebody whose level of function is already pretty low, and they dwindle and dwindle and dwindle and dwindle, and then finally pass away. Now, this is people in their 80s to 90s. This is called the dementia infancy trajectory or the dwindling trajectory, and this is going to affect 50% of us. So, with longer lives, as people enter the 80s, this is what is going to happen. And again, remember, Atal Bihari Vajpayee just vanished after the election that he lost, and literally we knew of him only when he passed away, finally, almost 14 years later. But there's a fifth trajectory which has been identified more recently after the paper that I showed you. And this is the catastrophic event or neurocritical care trajectory. Now, typically, this affects people who have some kind of severe brain injury, right? So this could be a stroke, a bullet, traumatic brain injury, whatever. And in previous years, these are patients who would have died. But because of neurocritical care, they are saved. But then they survive at a much lower level of functioning until eventually they pass away. It's now being recognized that this may affect high functioning elderly with systemic acute problems also. So you may occasionally see somebody who's elderly but doing very well, and then they get a hip fracture, and then before you know it, they are bedridden until they pass away. So we call this the fifth trajectory, that of critical illness. Right. So in all these trajectories, can we foresee and foretell death? And is it all that important? Remember that as long ago as the time of Hippocrates, it was said that the physician has the responsibility of cultivating prognosis, because for various reasons, but for one, as he intuited, for our own credibility. But I'll explain more about that. Can we predict mortality, say, about 1 year on? Now, you may think that that's pretty difficult, but no, statistically speaking, you can. So there are multiple scores of this kind. This is probably the Walter score, and its elucidation is probably the best that I have seen. So look at this. This is applied, say, when an elderly patient is discharged from hospital. So if you see an elderly patient who's male, who needs assistance with all activities of daily living. When we say activities of daily living, this means bathing, toileting, dressing, eating, and transferring from bed to chair. So 5 basic activities of daily living, needs assistance with all 5 points. So 1 point of this, 1 point of this, and say they have something else. Maybe the creatinine is in the CRF range. Anyone who has more than 6 points has a between 60 to 70% chance of passing away in the next 1 year. So if you look at this patient, if you look at this cohort, 70% gone in 1 year. And of the remainder, the same thing applies. So again, 70%, you can see that this points out a cohort which is likely to be gone 99% by 3 years. So if we know this, we have to also understand that this tells us that most deaths can be anticipated, except for a minority. And if you do anticipate death and dying, you can actually make for better outcomes with more people living well and dying in the place and manner of their choice. But that depends on us, because lay people don't have this information. If you look up the gold standards framework, it gives you a very simple algorithm for this whole business that I'm going to actually dive into it and explain the way this works for you. So there are 4 triggers that we use to recognize terminal illness, and I'm going to explain this. The surprise question, general indicators of decline, which are not really specific to a particular disease, then specific clinical indicators, which are related to your clinical condition, and decisional. When you decide that you're no longer going to take disease-directed therapy and go on to only comfort care. I'm not sure if any of you saw the small little news item about Jimmy Carter, the US he's the oldest surviving US president. About sometime last week, he together with his family decided that he would no longer take any kind of active medical treatment and he was going to enter hospice care at home. So he made a decision. Right. Let's look at the surprise question first. For patients with advanced disease or progressive life-limiting conditions, if you intuitively answer no to the following question, would you be surprised if this patient were to die in the next year? Or you could change the time frame to next few months, weeks, days. Now, this has to be intuitive. And you literally put together in your mind instantly clinical, comorbidities, social, and other factors. Who's going to take care of it, and so on. And the accuracy actually is pretty substantial. It's better than 70%. The more experienced you are, and it touches 80% in oncology. But as we know, oncology is a little different. Anyway, or you can take general indicators of decline. If you remember the score I showed you, you can either use that, or you can look at somebody whose self-care is limited, who's in bed or chair more than 50% of the day and requires help in most activities of daily living. This needs, of course, systematic assessment, and this is most accurate in cancer. But you can measure this. This is the Karnofsky performance score, and it tells you how you can actually put down these numbers. These numbers are indicative, and especially as you'll see in neurology, they are not so easy to apply. But whatever it is, if you have anybody who's declining in this fashion and has comorbidities, comorbidities are the biggest predictive indicator of mortality and morbidity. So if you have 2 or more medical conditions, then obviously mortality goes up. If there is advanced disease and symptoms are deteriorating and are difficult to control, so somebody who's now requiring O2 at home, or in Parkinson's, even severe constipation to the point of obstipation, that's a marker of end of life. Or decreasing response to treatments when diabetes can no longer be controlled. Now, some of the indicators that we found useful is, one is progressive weight loss greater than 10% in the past 6 months, and serum albumin less than 2.5. That's a marker. So you see these patients who seem to be in bed and whose arms and legs are beginning to swell because of hyperproteinemia. The second is repeated unplanned or crisis admissions, more than 3 admissions in 6 months, and again, that's a marker. And the last is a little difficult to understand, a sentinel event. It could be a serious fall, maybe not even a fracture, but the most important sentinel event for many people is the loss of a spouse, their main caregiver. Let's look at disease-specific indicators. Now, we've spoken about this, but this becomes the most predictable for cancer, and that is because once cancer crosses a certain point, remember the waterfall trajectory? It's cancer biology that makes all the decisions. We don't. So if there is recurrence and or metastasis after initial therapy, especially with multimorbidities, and if the performance status declines to the point that they are spending more than 50% of the time in bed or lying down, prognosis is estimated to be about 3 months or less. Just to point out that it's pretty unusual for Indian physicians and oncologists to give this kind of a prognosis in numbers. When we look at organ failure, it tends to be erratic and unpredictable. I mean, again, this comes from the gold standards framework, and you can look up the individual items in the list. I'm not really going to go into this in detail, except to point out how this works, say, for instance, for hepatocellular liver problems. If somebody has hepatocellular carcinoma, advanced cirrhosis, and liver transplant is contraindicated. any of these are markers that the end of life stage has begun. And you need to be preparing for them passing away within 6 months to a year. But unlike cancer, where you can actually say 3 months or less, that doesn't work here. When it comes to neurology, it's even more complex. Say, for instance, if you look at dementia, if somebody has severe dementia, cannot walk, is incontinent, has no conversation, unable to do activities of daily living, you know what? If you put a rice tube in this patient, even though they are effectively close to the vegetative state, they will survive another 2 years. So, neurologic prognosis to some extent is decisional, and we'll come back to that. And so this is the kind of situation where you look at symptoms which are complex and too difficult to control. You look at swallowing problems, speech problems, progressive deterioration, and at some point, the family, preferably the patient, decides that there should be no life-sustaining therapy from this point on. Right. So let me show how this works out in the form of patients, and we'll then stop for some questions because before we go to the next section. So this is an 81-year-old gent, retired bureaucrat. In January 2014, started to become forgetful. There was a diagnosis of mild early dementia and mild depression. And when he asked the neurologist, "Ab kya hoga? What happens next?" he got no meaningful answers. He had an active social life. In fact, he had been working till 2 years prior to that, but resigned because he said, "I cannot cope and I want to take leave." And as so often, sorry, what happened? Yeah. And as so often happens, his children are not living with the old couple. So over the next 3 years, he began the decline continued. In 2015, he could maintain his independent daily routine, but once he got lost in the neighborhood, and he started to becoming repetitive. His wife was getting quite bugged because he'd ask the same question again and again. By 2016, he started needing supervision at his, although he could do things himself, somebody needed to keep an eye on him. By 2017, there were behavioral issues. There were intermittent angry outbursts, one episode of nighttime wandering, and in January of 2018, he developed delirium due to urinary tract infection. He was found to have a hyperfunctioning detrusor, and he got a suprapubic cystoscopy. Now, although he was mobile in the house, he needed full supervision for all basic activities, and at times even needed support. And now it was his wife who asked the neurologist, "Ab kya hoga?" And he said, "This is expected with old age, not very meaningful." So towards the end of this year, again he got admitted, and this time he came in with low sodium. And unfortunately, when he came out, he was nearly mute. All basic activities were completely dependent, and he was bedbound. A month later, he had recurrent generalized seizures. And when he came into the emergency, he got intubated, treated with levetiracetam and phenytoin, and the seizures were instantly controlled. So you wonder whether he actually needed to be intubated. There were no obvious metabolic cause. Even though he was easily weaned off the ventilator, a tracheostomy was put in on day 8. But when it came to putting in a peg, the family balked. And they insisted on involving pal care, but finally a peg was put in and he was discharged to home care. When he was discharged, he was literally in the vegetative state. And the US-based son who had finally landed up said, "Could we have involved palliative care earlier?" So he was being managed at home with hired caregivers, and our palliative care physician was liaising with the family physician. But eventually he developed decubiti, and in March, he had an severe episode of aspiration, and he died. So you can see the missed opportunities for him and his family. At diagnosis, advanced care planning, if it had been introduced, he could have made his choices or at least given some idea of what he would like and not like. At the first admission, the family needed prognostic information that the dementia was now terminal. At the second admission, we could have started focusing on comfort, avoiding future hospitalization. Maybe he would not even have been admitted for the seizures. Maybe he would not have been intubated if DNI, DNR orders had been placed. And the tracheostomy need not have been done. The last stage of his illness would have been cut short by 2 to 3 months. So take the second patient, and this is the contrast that you will see. This gentleman, again retired, develops CA colon, and he ends up getting a surgery, June 2016. By the beginning of 2017, the left hemicolectomy had been done. He'd had a post-operative discussion with the oncologist, and he'd had 6 months of chemotherapy. And in August 2017, actually, he had his first encounter with the palliative care physician. This was because his grandson, who was based in the US, identified the need for this and made sure it was done early. And subsequently, he was on 3-monthly follow-up with the oncologist, except that once he had to miss it because he went off for his grandson's graduation. Now, in November 2017, a follow-up PET CT picked up extensive metastasis. And the expected survival that the family was told was about 4 months. He was not told. As he said, "Meri beti se baat kara, mere se nahi baat kara." Anyway, so he was offered palliative chemo and was told that with targeted therapy and with the expenses that it would come with it, he would get a best case survival of 24 months, median of 8 to 10 months, especially the lower figure, since he was already 75. So he said, "No, I don't want this." Chose the palliative care option. And palliative care team did a home visit. Hospice care was set up to manage symptoms. And see what happened. In April 2018, he had a prolonged discussion with the palliative care team together with his wife. His daughter and grandson participated on Skype. The grandson had just started a new job. He actually took 2 months leave and flew to Mumbai to take care of Nana, because now everybody knew what was coming. At this stage, he was in bed most of the time. The grandson helped both of his grandparents to fill up the advanced medical directive. By May 2018, Aman was completely bedridden, appetite down, and the daughter flew in. He literally waited to greet her, and the day after she came, he slipped into coma and passed away. So you can see the difference here between neurologic or non-oncologic death and cancer deaths. In cancer death, you have a defined trajectory and prognosis if informed. Admissions are avoided and patient and family retain control if there is transparency right till the end. This is because the patient is conscious, generally, unless there's neurologic involvement, is conscious till there and able to make their own decisions. What happens in non-oncologic death? There is an erratic or prolonged trajectory. There are recurrent admissions, which may be unavoidable. In dementia, there's an early loss of personhood. The decision making that the cancer patient can do at this point, this person has already lost at this point, right? And there may be expensive and avoidable ICU care at the very end, especially in say, for instance, in hepatic failure or in chronic kidney failure, because, well, it's the rule that they have to die in the ICU, isn't it? So, what is the diagnosis of old age? Remember that life expectancy is not expected to increase much beyond 80 years. So we need to know sentinel events, and we need to be prepared to take care of our patients when we know that they might start going downhill. Now, how do we do that? This is again the importance of prognosis. Let's take the third patient. This lady, 80 years when we first started, in November 2014, moved to Nasik with her 87-year-old husband to live near and be supported by her only daughter. The reason was a medical condition. She had poorly controlled diabetes on insulin, and she had episodes of hypoglycemia and decay. So the daughter said, nothing doing, I can't take care of you. I think they were in Pune, and uh, the daughter made sure that the old lady got a cook and maid and everything. And she was doing fairly well. About little less than 2 years later, she had an episode of febrile diarrhea, collapse, needed admission, but was discharged. Another 6 months later, a fall at home, fracture neck femur, needed hip replacement, post-op delirium, but recovered well, and then walking with walker. So you get the sense that somebody is starting to run into problems. In 2017, about 4 months after her last admission, her husband collapsed after 3 days of vague chest pain and mild fever, which turned out to be lobar pneumonia. And there was multi-organ failure. The old lady confirmed DNI and DNR, and he passed away within 48 hours. Why did this happen? How did this happen? In January 2017, after her last illness, when she had the bad fracture neck fever, both husband and wife spoke to their daughter and made it clear that there were going to be no heroic measures for either of them. And in fact, they said their bodies had to be donated to the medical college. Well, in April 2017, after her husband passed away, the granddaughter moved in to live with her. The old lady, in some ways, she was living in a sense day to day. For her, she said, I'm quite happy because her favorite person was living with her. But another 7-8 months later, her diabetes was poorly controlled and she developed multiple superficial soft tissue abscesses. She was admitted twice, treated with IV antibiotics, and finally discharged for home care with daily dressings. And when she asked, what is happening to me? She was told the medicines are not working out. And she said, okay, I will not go to hospital again. And in fact, she refused any painkiller stronger than paracetamol. And now you can see what happens. By the end of April, her activities were reducing. She was needing help with all basic activities, except feeding. She could eat, but her appetite was minimal, barely a couple of spoonfuls at a time. And by the second week of June, she entered into delirium. She had a certain amount of pain now. Hands and feet became cold. She became incontinent. There were small quantities of dark urine. 3 days after this started, she actually stopped speaking and stopped breathing later the same day. So you can understand that in all these trajectories, yes, we can foresee and foretell death. Sorry, I need to, okay, I'm coming back. But just look at this highlighted portion here. Remember that foretelling death requires us to communicate prognosis in a fashion that is honest, accurate, and yet optimistic. And we find it very difficult. Before the middle of the 20th century, diagnosis, therapeutics, and prognosis were three equally important functions. As medical treatments and diagnosis improved, the skill of prognosis declined. In everything, if you look at our textbooks also, prognosis gets a very short paragraph at the end. And prognosis consists of foreseeing and foretelling. Now, foretelling needs communication skills because you have to combine, as I said earlier, honesty, accuracy, and optimism. And I'll be a little blunt about this. If you do not commit to foretelling, your foresight will inevitably atrophy. Really. This is a skill that goes from end to end. You have to be able to perform it. So what do you need to communicate when somebody is at the end of or towards the end of life? We divide these into three broad categories. The first is goals of care. Goals of care is a less well-defined term. It's a clinician responsibility. You combine patient education and you discuss this with patient and family. It supplements the usual discussion about treatments, and it is done over multiple visits. Now, having done this, understood what the patient and family would like, then you need a system for documenting this information and making it actionable. And ideally, it includes choosing a proxy decision maker. Now, this has to be legally valid, which is the stage which we have reached finally now. But it also needs to be backed by public policy, which means hospitals, the government should make sure that these documents are made and they are available to all hospital systems and doctors. And then once you have this much information, then you combine patient and family inputs in terms of values and preferences together with the clinician input, which means prognosis and choices that are feasible. So you make appropriate in the moment decisions. Remember that when you're setting goals of care for patients and caregivers, you have to find out how much they understand, how much they want to know. You have to explain uncertainty. One of the clearest things that you can do is find out patients' wishes about place of care and does the caregiver agree? Because like my last patient, once she said she would not go to hospital again, most other decisions fell in place. And remember that wishes and plans may change. So when you do this, specific end of life decisions, sorry, yeah, okay, I'll finish this and then stop. When you do this, you understand that one of the clearest decisions that can be made is preferred place of care and or death. No intensivist that I know wants to die in his own ICU. Most people, when asked, say home. What about life-saving treatments? CPR, yes. Ventilation, yes. Dialysis, these are things that people understand. But people don't understand that even mode of feeding, especially when it is artificial, is included in life-saving treatment. And obviously, parenteral medications like antibiotics, chemotherapy, and IV fluids actually have to be. If you do this communication well, it improves patients' quality of life because it gives them a sense of control over their last days, and it reduces the burden, stress, anxiety, depression in surviving family members. It reduces the use of unwanted interventions and so on at the end of life. Now, the challenges are from the patients, from everybody's side, is the fear of death, difficult to think or talk about, and for the clinician, people think lack of time, which is not really so. We don't do it mainly because clinicians do not see it or see it and ignore it and don't know how to handle it. And as I said earlier, if you do not know how to foretell, your foresight will atrophy. To communicate, remember that this communication that we speak about, it's a learned skill as much as surgical or diagnostic skills are. It requires training, plus mentorship and supervised work. It requires practice. It requires assessment and certification. Finally, it requires performance. And each time you perform this, you need to prepare, you need to go through the procedure and review. It is the basic skill for palliative care. You must learn and acquire this skill. Unfortunately, most of my senior colleagues think that they came out of medical college trained in communication skills, and they find it very difficult to understand that the senior most doctor still can be absolutely bad in communications. Now, I'm going to stop at this point to take questions. Sridevi, any questions in the chat box?
No. There is nothing.
Anybody has any questions, please put them up in the chat box, because the next section is management of active dying, and you can probably put both of them together, and then we'll finish that before I go on to the last section. The next section is shorter. Next two sections are short. This was the big one. Nothing? Okay, let's go on. Right. How do we know when a person is actively dying? Now, this is a purely clinical judgment, clinical science, clinical symptoms. Active dying refers to the hours or days preceding death, during which time the patient's physiological functions wane, and we need to prepare the family and caregivers. The care now needs to be clearly multidisciplinary and holistic. And we also need to look at after that means bereavement care. Months to weeks before death, we enter a stage called pre-active dying, and this consists of physical and psychosocial withdrawal. Now, this timeline that I'm giving you is most accurate in cancer. In, say, for instance, in dementia, this pre-active dying may be not months to weeks, it may be months to years. And in cancer especially, ambulation goes down. We said 50% reduction in activity, withdrawal, decreased intake, occasional incontinence, increasing fatigue, weight loss. And this basically is marked by withdrawal. Then comes the beginning of active dying, and this is weeks to days, and this is marked by delirium. So there are episodes of confusion, the blood pressure declines, the pulse starts to becoming irregular, they become more and more drowsy, and then the intake and so on start to go down. And then finally, there's reduced communication or inability to speak. Days to hours before death, vital signs start to deteriorate. Consciousness goes down, breathing becomes irregular. Because they cannot swallow secretions, you get what is known as the death rattle. We'll speak about that. The face may relax with loss of wrinkles, and the face becomes yellow. And for me, one sign that I often check is gasping. Gasping is mandibular movement, and typically we're not very sure why this occurs, but we think this is due to brainstem hypoxia towards the end. Right. So our goals of care are to ensure that the patient is comfortable. You have to make the end of life peaceful and dignified, and make sure that the memory of the dying process is as positive as possible by focusing on comfort. And well, one of the things that we do is make sure that unnecessary medicines are stopped. So we know that there are going to be challenges for oral intake because of diminishing appetite, maybe even inability to swallow, stomatitis, and so on. So what families need to understand is that feeding tubes do not enhance survival or quality of life at the end of life. In fact, if you put in a tube, patients get agitated, you need to tie them down, and they run the risk of pressure ulcers. And they do not reduce the risk of aspiration or pneumonia. So you have to make an overall decision about artificial hydration. And ideally, I mean, if it is there, then review rate and volume to individual need, and make sure that the person is not overhydrated, not bloated, for instance. You have to remember that the body is shutting down and intake is going down accordingly. Total fluid requirement is about 1 liter per day. And you can confirm that if the patient is passing about urine about 4 times a day. If the urine output drops below that, then you know that we passed that point. Again, we avoid IV fluids. And what we focus on is hand feeding or with spoon feeding. The aspiration risk is actually manageable. And the way I put it to families is that when you were a child, for instance, for somebody's mother, I had said that when you were a child, she fed you by hand. Can't you do that much of service now to feed her by hand? And people understand that. You have to stop all medicines that are not required for symptom control. And if at all there are important medicines that are needed for symptom control, that can be given subcutaneously. Stuff like IV antibiotics, aspirins, statins. Aspirins and statins are meant for the next decade, not for the next few hours. Supplements. Sugar because of intake and sepsis. Sugars are dropping. Why do you need anti-diabetic medicines? Other stuff also needs to stop. And when you do this, you realize that so much of the load of the family goes off once they recognize that medicines don't have to be pushed in. The symptoms that bother the patient and family are these: pain, delirium, incontinence, dyspnea, nausea, and vomiting. Sweating and fever are relatively easier to control. And whatever medications you need to give, unless you have existing lines, say IV is not possible, ideally this is subcutaneous. Though of course other means are also used, but most people prefer the subcutaneous. The most common symptom is pain. Very often You may not be able to assess it verbally, and then you can use scales like the PAIN-ACT. You can look this up. Ideally, you should anticipate and treat it effectively. You need access to opioids, and the most reliable route is typically subcutaneous, unless, of course, you do have some kind of a line in place. And sometimes in severe pain, you may need to titrate it rapidly. If somebody is restless or agitated, the first thing is to look for the correctable: retention, constipation, pain. Then medications like anticholinergics need to come off. You need to increase their sensory input. So glasses, natural light, hearing aids, if possible, try and get them out of bed. Stop unnecessary noise, put familiar objects, and engage them in conversation, but don't shout at them, so that if they're resting, let them rest. If this does not get controlled, then the drug of choice, not by evidence, but by experience, is haloperidol. Benzodiazepines actually can be activating in this stage and can worsen delirium. So we generally don't use them. What if somebody is breathless or is conscious but is showing signs of air hunger? Well, the first is correct the correctable. So if there is large pleural effusion, reduce that. If you need, give diuretics. One thing that works is air movement on the face. So a fan close to the face really helps. Then you reduce the perception of dyspnea with morphine or anxiolytics. And if there is no respite, then this is an indication for palliative sedation, and we'll speak about that. What about nausea and vomiting? Again, correct the correctable. So constipation, hypokalemia, and hypocalcemia need to be checked for. The first line drugs are metoclopramide and ondansetron, but haloperidol is also used. Adjuvant drugs, you can use dexamethasone. Then there are second line drugs. And you will see that the list of stuff that we use are not the same as stuff that we use in walking, talking OPD patients. Pooled upper airway secretions produce a death rattle. And this is because swallowing reflexes are inhibited, so they're there in the pharynx, or bronchial secretions cannot be cupped up, and they again make this noise. And once this starts, then almost about 70 to 80% patients pass away within the next 72 hours. The management is non-pharmacological. But the first important point is to educate the family that this is not causing the patient any distress. Repositioning, removing the secretions by hand, this is important. You avoid suctioning because it's uncomfortable and it actually stimulates more. If at all you need pharmacological control, you can use glycopyrrolate. For the nurse, it's important to go through mouth care, pressure sore prevention, Foley's catheterization, and you monitor for constipation. And then you prepare for the end. Typically, most patients, it will be stopping breathing and or the heartbeat just stops and they pass away. But there are two dramatic ends to life which you need to be aware of and be prepared for. One is fits or epileptic seizures. This is, I mean, when it's a neuro case, you should be prepared for this, but it occasionally occurs even with other illnesses. What you need to do is prevent harm. Do not force objects into the mouth. No oral medications. You have to prepare with subcutaneous midazolam or anti-epileptic drugs. Levetiracetam and phenobarb are quite appropriate. Remember that the patient will gradually become unconscious because the brain and the muscles become exhausted and eventually they pass away with about 24 to 48 hours. And that again becomes a fairly quiet exit. But that initial period of jerking is an emergency and you need to sedate the patient. The second is this blowout hemorrhage. Now, this occurs with oral malignancy because the neck arteries get infiltrated, and you have to discuss this in advance with caregivers. Apply steady pressure and quickly sedate the patient. Again, exsanguination and death will occur fairly rapidly, and you actually need to be with the patient until the end is. Quickly to discuss palliative sedation. Now, palliative sedation is the use of sedation to make somebody comfortable and put them and to provide them with sleep. They are dying, but you may hasten death in this process. But that is what is called the double effect. You are not intending to terminate life. You are intending to provide comfort and sleep. As opposed to euthanasia, where the intent is to terminate life and the natural process is actually stopped and taken over. And death is actively accelerated. Now, throughout this process, the family may be suffering as much and maybe even more than the patient, and you need to address all their needs together the rest of the team. Once death occurs, remember that if you are called in, introduce yourself. The family may or may not be present when you do this. Wash your hands, confirm identity, watch for signs of life, especially breaths, check for responses, including pupils, feel for the pulse, wait for at least 3 minutes, then wash hands and exit, and then obviously document and do whatever else is required. Remember that somebody who's dying has rights. The first is to be treated as a living human being until death. Ideally, the individual should be able to participate in decisions concerning their care and to be able to die in peace and dignity and to be cared for by caring, sensitive, knowledgeable people who will attempt to understand the patient's needs. Once death has occurred, for palliative care units, it's important to collect back unused opioids. That's one of the purposes of a bereavement visit. But the more important one is to support the family. They have to be explained how grief will occur. Explain that grief will go on for some months and it occurs in waves. So the person who is bereaved will remember the person who has passed away, and it becomes like the grief comes up and then it fades. And you have to explain that these waves will come and go. Of course, some individuals undergo complicated grief, and we'll talk about that. Remember that supporting the family, the first and most important is anticipatory guidance. If they are explained what is happening, what is likely to happen, and are prepared, then they are ready to accept it. You have to listen and be available to answer questions. You have to address religious concerns and so on. And ideally, you should enlist help of medical team and volunteers in the community. Now, bereavement is a period during which mourning and grief occurs. Remember that grief is a natural distress, mourning is the outward expression, and most people with serious illnesses and their families will have had many losses during this illness. Everyone will experience grief uniquely based on factors such as culture and religion, nature of loss, especially a sudden death, and say the spouse. So that becomes very, very severe. And remember that grief actually starts before. This is called pre-death or anticipatory grief. And the other types of clinical grief that we need to recognize are acute, integrated, and complicated. Acute is the period immediately after death and dying and up to about 6 months, that intense separation, distress, and emotional pain that follows the loss of a loved one. And it involves an evolving process of adapting to life. Once it is integrated, there is an understanding that this is final and the consequences of this loss are accepted and assimilated. But when the grief persists for an extended period of time and exceeds expected social, cultural, or religious norms, the criteria that we use typically are 6 months. Then it is complicated grief and needs treatment. And we need to continue bereavement support for at least a year, including identifying people who are at risk of complicated grief, so that they can be given necessary counseling and so on. The key messages here are that terminal illness can be identified. We have to shift focus to symptom control, comfort, and quality of life for patient and family. The active dying phase must be recognized, and the family must be prepared for the patient's death. Family support begins before death and continues afterwards as well. I'm again going to stop for a few questions before I come on to the last section, which is maybe about 10 or 15 minutes now. Any questions here?
Anybody?
Good afternoon, Doctor. Just one question I would like to ask you, which is actually a complicated question. When do we decide that? When do we decide that now it is time to stop everything, stop the medications, and there is no use of continuing it? Like, when can we very confidently say that to the relatives or the immediate bystanders? Like, what is your opinion?
So you are asking, yes, obviously. So this
It's
is
a
this
very
is
complicated question. Sorry.
not really. You need to understand that the lecture that I gave you, once you start accepting that you need to learn these issues, you will start to identify these points. It's not as though this is not something that cannot be learned. And as soon as you're prepared and as you read up about this, remember that you basically have to identify pre-active and active dying. If it is pre-active dying in cancer, you can be reasonably certain. But for non-oncology, you have to be sure that you are at the stage of active dying. The other issue is actually something that I'll address a little further. Remember that in most of these things, you said, when do I decide? Please understand, you are not the person deciding. As far as possible, it should be the patient and family deciding. You are supporting them in making their decisions. So, when I come on to the next section, you'll understand that that's what we need to aim at, patient autonomy. Anything else?
Thank you, Doctor.
There is another question regarding use of antibiotics and at the end of life.
Okay. So the use of antibiotics, antibiotics are indicated if they are being used for symptom control. So somebody has a bad abscess and it's causing pain, you give antibiotics. But somebody has lobar pneumonia and has decided that they do not want to be intubated or ventilated, then why would you give antibiotics? If it is UTI and sepsis, and again, say it is end-stage dementia, why would you give antibiotics? So we call these heuristic decisions. These are not decisions that have an evidence base. These are rule of thumb. So you actually need to go into these decisions with an open mind.
Sir, I had a question. This is from the previous section. The Walter score that you mentioned, that took only the male sex as the parameter.
No. Male sex got 1 point.
Yes.
So males have a worse prognosis, slightly. That's all.
But so it's not applicable for female patients.
No, I mean, if you take 2 patients with everything else being equal, then being male gives 1 more point.
Okay, sir. Thank you.
I'll move on. Chale?
Sir, and how to decide on the intervention procedures to be avoided in the advanced stages of diseases, like stunting in case of hydroid necrosis or
So for instance, you're not going to be doing stenting when somebody is actively dying. So, but if somebody has obstructive jaundice, then you would like to do it. Say, see a pancreas obstructive jaundice, you'd want to put in a stent, no? To make sure that they don't die scratching themselves to death. But for instance, if somebody is in that kind of stage, I would not recommend cardiac stenting, definitely. So stenting, I mean, again, palliative procedures, palliative interventions until the active dying phase are all indicated.
okay, sir.
Chale, next.
Yeah.
Oh, sure. Now, this is maybe a little, you may find it entertaining, painful, whatever. See, the problem is the medical profession shies away from these issues. And when people outside, civil society looks at us, they wonder why we don't see what they see, obviously. They wonder whether these are perverse incentives, whether we make money out of prolonging people's misery. Is it because we work in corporate hospitals? And a friend of mine said that a corporate hospital is one which the poor cannot enter and the rich cannot leave. So, these ideas float around. But what doctors feel is that there's a lack of legal clarity. There are no clear regulatory requirements, no law saying that thou shalt not on pain of. There is none. And you have to understand that practically no country has clear, complete end of life care laws. No politician wants to make these laws because they are going to be asked, you haven't given us good health care. How can you make a death law? So these usually evolve within countries, usually through judgments, or a law may address a specific point and so on. And because of this, there is this vague fear of criminal charges and litigation. But I think in addition to that, what we don't say is that we find it difficult to establish prognosis. And you heard me on that. But the most important is that, and which we will not admit, is that we lack the capacity to engage in palliative care or end of life care, and we have no clue how to communicate. We communicate so badly that we shy of it, and we actually don't do it. So I think that these are skills that we all need to acquire. Now, when you look at the whole process of making these decisions, remember that laws and judgments are based on ethics and constitutional morality. You may have heard this term constitutional morality. It comes up, Supreme Court judges say that to the government. But these translate into laws and judgments. But remember, laws and judgments take into account our practice, our guidelines, and then eventually you get laws, policies. So we are part of this. This comes from us. For us to insist that everything has to come top down is wrong. Remember that long ago, it used to be that the doctor knows best, but we reached human equality. Together with medical progress, as ICU care, organ transplants happened, people started to survive bad illnesses. They went into ICUs and came out alive. But the flip side of it was that death became medicalized, so that people stopped dying at homes and they started dying in ICUs and hospitals. But simultaneously, medical paternalism was ending. Informed consent has been around since the 30s and 40s, but patient autonomy and rights started to actually be taken up as a concept from human rights. So a human rights lawyer was the first person to write a living will. And as it started in the USA, it became a kind of a competition between various states, so that the USA became the world's laboratory for living wills, advanced medical directives. Eventually, the federal government passed something called the Patient Self-Determination Act, which only says that any hospital that is paid for party or wholly by the central government, must ask the patient if they have made a living will or if they want to. Right? Now, this was happening in the US. On the other side, from the UK, palliative care had effectively just been designed by a very remarkable woman. That's a whole different story. So that was spreading from the UK. Now, when we look at these issues, we think of it as all being based on ethics, autonomy, beneficence, non-beneficence, justice. This is another lecture that I can give, but remember that it is not so easy to apply these to cases in front of us. And we use something called the 4-box model. Again, this is a lecture where you combine these into medical indications, patient preference, focus on quality of life, or contextual features, which means, for instance, in the COVID pandemic, ICU bed for a VIP with dementia meant that a young individual who could probably survive and do well would not get it. So these are the things that we have to put into account. When we look at the legal framework that we have, it starts off with the Constitution of India, but then we have common law, which means that this is done as part of the judgments that evolve, as part of our usage. The only real law we have is THOTA, the Human Organs and Tissues Act, transplantation. Then, of course, we have various professional guidelines, and then we have IPC, Mental Health Care Act, and so on. I have been involved in this topic since 2011. I was part of the medical panel that was called in by the Supreme Court to look at the case of Aruna Shanbag. And in 2015, Three national medical associations came together, the neurologists, the intensivists and palliative care. And since then, we have been involved with this topic. In the first case itself, Aruna Shanbag's case, remember the one thing that came out of that was this whole process got decriminalized. So after that, whenever anybody said to me, "Arey, you'll go to jail," I said, rubbish. That the Supreme Court has very clearly said that this decision making cannot be termed criminal anyway. But of course, this judgment did not lead anywhere because obviously it was ahead of its time. In 2000, somewhere around about a little after that, and up to 2014, the Indian Society of Critical Care and the Indian Association of Palliative Care got together and put together end-of-life care policies, which integrated whatever was best applicable from elsewhere. But as you can understand, this was done in anticipation of legal clearance. So in 2018, we got some legal clearance, but that legal clearance that we got was only constitutional. And the judges were very clear. They said it that all citizens have medical autonomy. A competent person who has come of age has the right to refuse specific treatment or all treatment or opt for an alternative treatment, even if this decision entails a risk of death. You can treat an emergency only when it is not practicable to obtain the patient's consent. But where a patient has already made a valid advance directive, which is free from reasonable doubt, specifying that he or she does not wish to be treated, then such directive has to be given effect. The problem is that the procedure that they set out was pretty complicated and actually put off lots of people. From then till the beginning of the pandemic, our group worked on the DNAR document that was put out by the Indian Council of Medical Research. We prepared a standard format advanced medical directive, which is available on the Pallium India website. Manipal Hospital, Kasturba Medical College, Manipal put out a proper document for their own hospital to use for foregoing life support. We worked with FICCI, and then just before the pandemic broke out, AIIMS New Delhi put out a fairly nice end-of-life care guideline. Now, remember that these are all in the public domain. But because the process that had been set forth in the 2018 judgment was so complicated, we really didn't go anywhere really very far until January 24, 2023. So at that time, our application to the Supreme Court, this was placed by the Indian Society of Critical Care Medicine, and Dr. Raj Mani and Dr. Dhwani Mehta, who I quoted a little earlier, were actually in court when this whole thing was discussed. So you should actually read this judgment. There is a highlighted copy on the IAPC website, and it tells you clearly, read the highlights, because there's a lot of stuff there, verbiage there that you may not be able to read. But the highlighted portions tell you what is important. Right. So it's important to understand that this is all about patient self-determination and autonomy. Remember that our constitution gave us liberty, but the liberty needed to be extended to the personal space. And this happened with this judgment. Then there was a judgment on privacy. There was a judgment on sexual choice. All of these three judgments came out around at the same time. But we are concerned only with patient self-determination and autonomy. Remember that only a few countries have this legislation. Probably no country has comprehensive end-of-life care legislation from end to end. So as of now, it is these judgments all that we have, and these are the law of the land. But as I said earlier, we pay lip service to autonomy, and there is no autonomy without adequate information and communication. I've said this earlier. There is no app for comm skills. These are learned skills. You need to be trained, you need to practice, you need to be assessed. And then when you perform, you need to go through this cycle every time. Prepare, perform the procedure, review. There are lots of people who talk about how if you do this, somebody will file suit. If you do that, somebody will file suit. The fifth son from the US will come and file a murder charge against me and his eldest brother, or so on. That is all rubbish. In the United States, the maximum litigation is for what is called a wrongful life, because doctors ignore or bypass clear instructions, for instance, not to resuscitate. Remember that poor end-of-life care is one of the major causes of the systemic distrust of the medical profession in India. And we now have no excuses for not addressing this issue. So how do we do it? So there's a due process for foregoing life-sustaining treatment. And this is based on the papers that I showed you earlier, together with this judgment. Ideally, there has to be hospital policy. The first step is you heard of the first end-of-life care committee. That's basically the treating team. So there has to be a consensus of utility amongst the involved consultants, starting with the primary. Then you confirm the patient hierarchy and confirm that the patient and family are on board. Now, obviously, I'm saying that this, if it is a competent patient. If it is not a competent patient, meaning somebody who cannot speak, then the advanced medical directive, and finally, surrogate decision makers. And having done this, you have to complete documentation with a detailed note, and that has to be signed out by the appropriate surrogates and 3 consultants. The next step is a review by a standing body. This is called the second end-of-life care committee. The hospitals have to set this up. This requires 3 doctors, not part of the first committee, from the same hospital. The head ideally has to be nominated by from the government side, but from the same hospital. It could be a senior physician who's maybe not practicing too well, whatever. And the whole process has to be completed in 48 hours. Now, when I say when the 48 hours limit is set by the Supreme Court, but the hospital policy can say finish it in 12 hours. So you can understand that we now have no excuses. What about the living will? Remember that before this last judgment, nobody was making living wills because it had to be signed in front of a judicial magistrate first class, and that was next to impossible. So now we can do it, and you have to begin this by speaking to those close to you. Choose your surrogates, confirm that they accept the responsibility, understand your wishes, and will follow them. And you have to decide whether they can have discretion or they are just supposed to carry out your orders. When you make this directive, it has to be signed in front of 2 witnesses and attested by a notary. As I said earlier, the sample form that we have made is available on the Pallium India website. It's also available on the IAPC website, and it is in consonance with our Supreme Court judgment. And you will see that if you read through it. I'm not going to go into this because this lecture is not really about that. So you have to choose at least, if possible, at least 3 surrogate decision makers. They don't work as a committee. It's basically if one is not there, then the second. If second is not there, then the third. And obviously, this has to be signed out and made valid. I tell my patients that they have to show it to every doctor they consult, because they'll find out if the doctor understands it, will look at the hospital's policy, and more importantly, if the doctor will understand your wishes. What if this is not done? Remember that we now have the means to keep the body alive indefinitely should we choose to do so. I told you about Jimmy Carter, who has now entered hospice because he's decided that no further treatment there's any point in treatment. In 2018, 3 90 years old passed away, and 1 passed away last year, but I'll tell you their stories. Barbara and George Bush, April and November, passed away in their own beds, literally in Darbar, surrounded by dogs, cats, children, grandchildren, everyone. What about poor Atal Bihari? He died alone on ECMO, extracorporeal membrane oxygenation, in the AIMS ICU. Right? Think of the torture that that poor body underwent. Lata Mangeshkar got intubated twice. Right? So my rule is that if you are an Indian VIP, you are condemned to torture before death. So I hope none of you wants to be a VIP. I'm going to stop at this point. My email ID and mobile number are here. This presentation will be available to you as a PDF. But more importantly, if you run into problems, please don't hesitate to connect with me. I mean, obviously, reasonable time, giving time, and all that, and I'll try and help out wherever I can. I'm going to stop sharing, take a few questions, and unfortunately, I hope we have time for the case now.
Thank you, Dr. Roop. I can see Dr. Ravi Kiran was waiting for a long time. Dr. Ravi?
Go ahead.
Good evening, sir. It's a very wonderful presentation. I would like to know, when we explain the prognosis, the grave prognosis, avoidance of futile care, goals of care. Some of my oncologists used to say that patient caregivers do record those things, and this makes them uncomfortable to disclose the grave prognosis, and they used to
Run away from it.
involve those discussions as the caregiver. Some of them used to record or make a phone call in silent and made, so these things can legally bound to that to the oncologist, or they can use against them such things. Say
See, I think that if you do a reasonable job of communication skills, so what this recording bit happens even in the OPD. So if I see somebody recording,
Ji sir.
I obviously I give them a firing. I tell them that if you take my permission and record, I will be happy to let you record. But if you do it by subterfuge, that's not okay. And if your communication skills, if you're reasonably confident of your communication skills, why would you not let them record it? So it's up to you. Once you're confident of this, once you're confident of your prognostication, once you're confident of your ability to communicate this, what's wrong?
Okay.
Transparency is the key everywhere. Transparency is the key. You have to be transparent.
Fine. Thank you, sir.
Okay. Anything else? No.
Sir, when the patient's family asks opinions from us, like they don't make decision and they ask us how we will decide or what can we do, doctor, you say, tell us, then how should we?
Autonomy is not a one-stop process. Remember that we've had the way we practice, the way we communicate with them, and not everybody is willing to take on autonomy. It's a burden. But you have to explore this. And even when they ask you to take decisions, you're still going to explore their values before suggesting the decision to them. Again, you're not going to give the decision. You're going to suggest. And you will find that most patients will accept the suggestions. Maybe totally, they may, even those people who say you decide will finally change their mind. That's okay. So it's a process. You have to be prepared.
So also that we have to be, as you said, absolutely be transparent, honest. But at the same time, after giving the whole picture to them, we have to give them the opportunity to choose. That's what I do, because we should not take the onus of taking the responsibility to make the call for the family, because there might be different family members who might be having different opinions, and sometimes then that can affect our decision making. So it had happened to me quite a number of times where number of people having different opinions. Then I called all of them and I said, "This is your final opinion. I mean, decision, not mine." So the family has to decide whether they have to take them to the ICU again and ventilate, or whether they have to keep them in the house and do.
So what I do in this situation is give them the options. But remember, we are doctors. We can't give them a thali and say, you choose what you want from this. This is not a menu card. I actually say that if this were my father, this is what I do.
Yeah,
so
that is what I
used to be uncomfortable about putting my own feelings out. But now, one of the things that you learn with communication skills is that your feelings are a part of this process. And you should not, how do I put it? You don't have to be You don't have to be an actor, but at the same time, you're a human being. You're a person who feels that. So you can let them know what you think is right and wrong, but their choices are, yeah, they make the choice. I wouldn't say right and wrong. I say we use the term appropriate.
Yeah, as you said rightfully, I have done that on one or two occasions where I said, if it were my mother or father, I would have done this. And they have abided. One of them has abided by it, but the other one, who was a daughter from US, she had just flown in, and she was seeing the mother for a long time, and she wanted the best of care, as she was saying, and she wanted to take them to the ICU. I said, okay, it's up to them. But later, after the mother died, she regretted it, and she came back and said, I'm very sorry, we should have kept her here. I said, oh, it's all your choice. We can't impose anything from our side.
Absolutely. Anything else? Let's go on to the case. I mean, if anybody strikes any questions, no problem. Take more time later. I mean,
we will go to the patient story, and maybe we can discuss at the end if time permits. So today patient story is presented by Dr. Ashok Matthew.
Go on.
Hello, please share the presentation. And I know that Dr. Ashok Matthew has some problem in reading the presentation. So if any of you can volunteer to read this presentation, it would be good.
Okay, good.
Anybody who would volunteer to read this?
Yeah, I can read, sir. This is Dr. Puneet.
Yeah.
So this patient is aged 26 year, female patient. She was diagnosed as carcinoma right breast with metastasis to brain and left orbit. The presenting complaints were, she was referred to the Center for Palliative Care on 19th August 2022. She had a lump in the right breast, and it was diagnosed on September 2021. Biopsy was done, which was suggestive of invasive lobular carcinoma. She had pain of the back extending to both lower limbs, more on the right lower limb than the left. She was paraplegic, immobility below the hip. She had numbness of the fingers, mostly of the right hand. And she had a defective vision in her left eye. History of illness, presenting illness. On September 2021, a lump in the right breast was noticed. The biopsy suggested invasive lobular cancer. She underwent the right side modified radical mastectomy in the February 24, 2022. She received 4 cycles of chemotherapy, adjuvant chemotherapy, and the last dose was on May 30th. Complaints of left eye pain and ptosis. MRI brain and orbit shows lesion involving right perirollandic region and left caudate nucleus, right occipito-bilateral cerebellar hemisphere, right more than left, likely metastatic deposits in the left orbit. The palliative radiotherapy was given to whole brain and the left orbit. 8 fractions given till July 13th, as she could not tolerate until July. It was given. After that, she couldn't tolerate. Complaints of raised intracranial tension. Hence, she was started on anti-edema measures and supportive care. She complained of vomiting and progressive weakness of limbs with loss of bowel and bladder control. She has acute retention of urine, and she was on Foley's catheter. So on examination, the patient was conscious and oriented. She had no pallor, icterus, cyanosis, lymphadenopathy, or field edema. Temperature was normal, pulse 88 and BP 120/80, respiratory rate 14 per minute. Systemic examination revealed CVSRS normal, abdomen soft and non-tender. In CNS, the left eye had ptosis and proptosis both. The power was 3/5 in both the lower limbs and 3/5 in the right upper limb and only 2/5 in the left upper limb. Hand grip was 90% in both the limbs. The treatment and significant investigations were the surgery was performed in February 2022. The histopathology showed invasive lobular carcinoma grade 3. 4 cycles of neoadjuvant chemotherapy was given. MRI brain and orbit shows the lesion involving perirolandic and like multiple spots of metastatic deposits were seen in the MRI. Palliative radiotherapy to the whole brain was given. Left orbit also palliative radiotherapy was given, 8 fractions. After that, she couldn't tolerate due to LB, low backache and pain radiating to both the lower limbs. MRI pelvis with whole spine screening was done. No significant finding was found in the MRI. Then the patient developed increased ICT symptoms. So she was started on anti-edema measures and supportive measures were started. She complains of vomiting, weakness of the limbs, loss of bowel bladder control, and then she could not tolerate the brain radiation and which was withheld. Further radiation was deferred in view of the progression of the disease. Anti-edema drugs were tapered and stopped, and the steroids were also stopped. The oncologist started on letrozole, some hormonal therapy letrozole. Next, coming to the psychosocial aspects, she was the only child of the parents of poor socioeconomic status. She was married. She has 2-year-old son. The son is staying with she's staying with her husband and his family, as her parents find it difficult to look after the child and the sick daughter, both of them. So the son is with the husband. Family is very close-knit and supportive. The husband, along with the child, comes on every Sunday and spends time with her. A very positive lady, dreams of getting better and taking care of the child in future and sending him to the school. She and the family are fully aware of the gravity of the situation, but she is in complete denial. Need to explore more with the patient as the disease is progressive and end of life may set in. Need for support for the parents of the patient, the husband and the child as this disease is progressing. A warning shot was given to the parents as her symptoms are not getting controlled. The medications were, she was on Levipil tab twice daily, tab Emisset 8 mg thrice daily, Dalcolax 10 mg PRN, tab Nexpro 40 mg twice daily, tab dexamethasone 8 mg twice daily, slowly tapered to 2 mg twice daily. She was on tab letrozole 2.5 mg once daily, and initially on tab Ultracet as the pain was not controlled. She was started on morphine 15 milligrams Q 4th hourly with extra 10 mg for breakthrough pain. As her numbness and tingling was not adequately controlled, she was started on tab Lyrica 75 mg daily initially, but now increased to 150 mg twice daily. The main concerns in this case, the progressive nature of the disease, and the previous slide, please. Yeah, unresponsive to usual pain medication, increasing drowsiness, either due to medication or due to the progression of the disease, a warning shot to the parents as her symptoms were progressing, and end of life care has to be initiated with the warning shot. Next slide. Next slide. Summary. This is a 26-year-old young mother diagnosed with the cancer of the right breast with metastasis to the brain and the left orbit. She underwent the surgery followed by chemotherapy 4 cycles, and MRI showed metastasis in the brain and the orbit. The whole brain radiotherapy was given 8 fractions, and she couldn't tolerate and it was stopped. Anti-edema measures were started and then later stopped. Steroids were started and then tapered and stopped. She is on urinary catheter and diapers due to loss of bowel bladder control. She is completely bedridden, hence frequent home visit is done through the home care team. A hospital bed was given to enable her to sit up with support and to prevent bed sore. As she was able to stand with support initially, a wheelchair was provided to enable her to move out of the bedroom. Next slide. So the points to be discussed are like initiation of end of life care as the disease is progressive, and advance directive, if any, for the patient, and wishes of the patient regarding her child's future. And then need for individual and family counseling to prepare for the end of life care.
Thank you, Dr. Punita. Dr. Ashok, would you like to add anything else? Sir, please unmute.
Yeah. See, I mean, I just wanted to know, actually, Dr. Roop has given a very good description of how to identify the end of life care. I mean, end of life, so that we can practice that. But then, as he said, it is more of, practice. Then we will be able to, actually, we did not know how to do that process to the patient as well as to the parents, because she had already been on an end of life, as we know, when she came to us. But then we did not know whether to start then or wait for some time after counseling and then do. With the counseling, we were able to find out about the patient and her thoughts. And since she was so positive, we were reluctant to tell her that the progression of the disease. So I think somebody can discuss on that. I mean, Dr. Roop has given a very good description, and I'm very thankful for that.
Okay. Anybody would want to comment on the points that Dr. Ashok has mentioned? When would you start discussing the end of life care?
Yeah, sir, I feel that we should have started when she was referred to us itself, because at that time itself she was having I mean, she was bedridden, and we had to go to her house to see her many times. But because of the distance between the clinic and the house, and we were able to do initially once in, I mean, bi-weekly every month for about up to December. But then after December, we went weekly. But then she passed away in beginning of January. So I mean, we lost initiating the end of life care, or I mean, I don't know whether we did it right or wrong. I don't know. I am not very sure about that.
Good. I think you took good care of her. So, what do you think, Dr. Sunil?
Yeah. So the patient came late to them, and in a state of when the patient was bedridden, and so Dr. Roop has mentioned about the surprise question. Would you be surprised if this patient we cannot see him in 1 year? So those are some surprise or questions which we can use to see whether this patient is at the end of life. So as Dr. Roop has correctly pointed out that the period of end of life is up to 1 year. So 6 months to 1 year is also called as end of life.
Quite right. Good case. I mean, it covers all the points that we made.
Only, sir, the only thing we could do was we could able to convince the parents, because they were very receptive, and they also came to understand that the progression of the disease. But it was very difficult for us to explain to her, because every time when we go there, she is talking about a child and very active. But towards the end of the night, because I mean, towards the end, like, end of December, we went there, and she was so drowsy, she cannot even tell anything. So we were just worried. That time only we gave the warning shot to the parents, saying that she is moving, progression of it going on, and she may move into death anytime. anything should I do? I mean, what else could I do?
No, I think you did whatever was correct. I mean, if the patient refused to accept her diagnosis or refused to look at it, fair enough. You meet the patient where they are. You took care of her symptoms. The first priority is taking care of her symptoms, and you did that. So I wouldn't, the patient doesn't have to accept that they are dying as long as you are managing the symptoms.
Okay. Thank you.
Sir, we have faced situations where the relatives will come and say, not to tell the patient that the patient is dying. And as there is no point in telling that the patient is going to die, we accept that, but not as a collusion, but at the same time, we do everything for the patient, knowing well that the patient is dying, and the relatives also know the patient is dying, but we don't bring that subject up with the patient directly. And I believe that the patient themselves will know towards the end that they are moving on, so though it is not obviously brought out, that will be understood. But as Dr. Roop was saying, if we have done everything for the patient to relieve of the symptoms and taking care of them in a comfortable way, I think that is our job, basically.
If possible, I mean, because this issue of collusion keeps coming up repeatedly. So what I do, I mean, for me, it's more important because these are neurological patients. And as I said, in cancer, the patient can still speak till just a few weeks before, right? In my patients, they will lose this ability months, maybe years before. So it's important for me to ask the patient if they want to know the diagnosis. And even before that, if there is an inkling that the family may push for collusion, may ask not to tell the diagnosis, then fairly early, I ask the patient to tell me whether they would want to speak or they want somebody else to speak. And I try and give that patient the choice. If the patient says, no, I don't want to speak, that's fair enough. But they are given this opportunity and they are told to come back for a follow-up visit once they have decided. This occasionally can get a little awkward, and I won't deny that some patients may not come back. But if I'm, say, for instance, taking care of a patient with motor neuron disease, how can I give them palliative care without their cooperation? I have to talk them through putting in a peg. I have to talk them through so many things. So these are choices that one makes that partly also depend on the etiology. In cancer, it's a little different, right? But even there, I've heard stories about somebody who was not told and who got very upset because she said, you didn't give me the time to make my choices clear, to at least do what I had to do before I became too weak to do anything. So when this request for collusion comes up, the first thing is to make the family aware of what the consequences of that collusion will be, and leave it to them, between the patient and the family, to choose who will speak to you. I think that's the least we should try and do.
Yes, sir. We don't obviously participate in the collusion, as you said, but in a very advanced case, especially when the patient is coming to us in a very late stage where there is nothing much more to be done other than end of life care, then obviously the patient would also guess that after chemotherapy, radiotherapy, surgery, that there is something very serious more than what is being told, or more than what she understands. So they would be having an understanding about their illness, but they won't obviously talk about it. That is when we don't bring about it very openly. But as you said, when collusions had occurred, then I have objected to that. And I said that is not the right way of doing the things. And if the patient needs to know, then we have to let the patient know, which the relatives have later accepted, because the trust factor is also very important, because the relatives also should trust us and the patient should also trust us. Without the trust, we cannot move forward. So it's very,
One of the lines that I use for families, I tell them that you have never done this before. This is not your job. This is the doctor's job. And once you, in many families, once you accept that responsibility together with the understanding that you will take care of whatever comes our way, they do accept it. Dr. Matthew raised his hand.
Yeah, yes, sir. I have a small doubt. Should we, the wishes of the patient regarding the child's future, do we have any say on that? Like, I mean, we leave it to the family to decide about it, or can we get it from the patient and then work on that?
He has a father.
Yeah, okay.
Yeah, another point which I would like to add is to bring out the issue of the child. Actually, the patient should know about the seriousness of the nature of her disease. So,
Yeah.
if she knows about the condition, what she is going through, then we can ask her about what is in your mind about your child. So, some people actually plan it. So right now we have a patient who has planned everything for the child, for her child. So this can be actually it will be beneficial for the child also once they grow up and when she thinks that her mother has done all this for her, then that will be good from that aspect also. But I think it is important for us to talk to the mother regarding that insight, and then we will proceed with questions about the child.
Okay, thank you.
Sir, can you talk about a little bit about advanced directive in this patient, Dr. Roop?
Right. So the advance directive has two basic components. The first is the living will, which is basically your expression of wishes of how you would like to be taken care of and so on, how much life supporting treatment, whether to use it or not to use it, which ones to use and so on. And based on your values, and values could be things like choice of being dependent or not being dependent, choice of how long you want to live, if it is possible, a choice of suffering or not suffering. So people make these choices as they go along based on their own values. And ideally that needs to come together in the document. The second is the decision about who will take charge when you are no longer capable of either making these decisions or communicating. And this is called the healthcare power of attorney or the proxy. And this person, typically we are supposed to appoint 3. So they're not a committee. They don't have a majority vote. It's basically number 1, number 2, number 3. They can talk amongst themselves, but it's only number 1, or if number 1 is not present, then number 2, or then number 3 who actually does the signing. It's important to decide whether the proxy has any discretion or can only carry out your wishes. But there are times when it may be difficult for everything to be predictable. So ideally, we think that advanced care planning, whenever somebody wants to fill in this form, they should sit down with their family, sit down with either counselors or doctors, and then go through this process. Dr. Agarwal has raised his hand. Dr. Agarwal, I think I can see one hand raised.
Hello. Good evening, sir.
Hi, Bolo.
Yeah, good evening. Sir, many times there are patients which are not under our treatment, but they are getting treated with some other doctor at some other hospital. And just because we are a family physician or they know us, they want to discuss these end of life things. And so in that case, how much should we talk and how to talk, because we don't have all the details also.
I think that this needs to be case by case. And ideally, this is always an awkward situation, that how much do you get involved? I have a personal perspective on this, that if it is somebody that I care for about, then obviously I'm completely involved. If it is somebody who's not too close, I will give them only general advice and leave it at that. But if at all, I will try and help them or point them to somebody who I think they should be connecting with. And well, you have to feel it. I don't think there are any very clear-cut rules on this in India. Given the fact that everybody is related to somebody or the other, it's always a problem.
Right. Okay. Thank you.
But sir, this patient, if we have to plan advance directive in this current situation, also we can record what, sir? She is having increased intracranial pressure. She might be delirious.
No, so at this stage, I don't think advanced care planning makes any sense. I mean, you have the main obstacle of her own sense of denial in that. The second is that with as she started to become delirious, she would start to lose capacity. And the third is that she has adequate surrogates. Her husband is there, her parents are there. So, I think I would probably not venture too far on that in this patient.
Sir, and before recording advance directives, mental state examination should be carried out or what, sir?
Okay, now that's a little tricky. So, in somebody who is in overt dementia or somebody who, say, has problems in articulation, in aphasia, then you need to go through a process of ascertaining decision-making capacity. You need to be you need to make sure that they understand the issue. They can understand what are the consequences of the decisions they make, and then finally that they can communicate. So it's a slightly complicated process when you undertake this in somebody who has already lost cognitive capacity. But we until the stage of moderate dementia, we can try, at least we can ask them who they would want to make decisions when they cannot make decisions. So that basic choice of proxy, they can make till fairly late. But the other details, no, you need to have decision-making capacity.
Okay.
Sir, I have a question.
Any more comments?
So should the sir, I have a question, sir. I'm Shravani. So should the representative who is chosen by the patient in case in an advance directive, like should he be there he or she should be there in person at the time of decision making, like in case patient loses capacity in the end of life? So should the representative be there in person, or can he like say over phone call or something like that? In that case, like
that is going to be a slightly tricky situation. I'm really not sure how things will go in our legal system and so on. But I mean, if you say that somebody has written a proper advance directive and there are 3 surrogates and number 1 is on the phone and number 2 is actually physically present and number 1 and number 2 are arguing. I would hate to be in that kind of a scene. But yeah, I understand what you mean. So we will probably, I mean, when we actually start having these situations, we will probably have more clarity. I personally would feel that since these are issues where you actually need to sign, the person who's on the spot is the person who matters. But if nobody is available, then whoever you can raise on the phone is probably okay.
thank you, sir.
Sir, you have brought out another issue where the number 1 and number 2, if they are fighting, I mean, then
number 1 decides. Number 1 decides.
Then number 1 decides. Okay.
Number 1 decides. Okay. Always. But if number 1 is not there, then who's going to decide?
Sir, have you
So
seen?
can't all the three people who are named as proxies, can't they all be told while making the advance directive to be in agreement and
So,
then sign?
see, that's a problem that it's understood that this can get a little complicated. So, uh, uh, we the form the way it is understood that it is in hierarchy. We would like them to be in agreement, but if not, then we finally we have to make decisions. No? So we will go by the hierarchy.
No, I mean the patient while making advance directive can ascertain that all three proxy are in agreement to avoid a situation where they may just disagree last minute.
I'm sure he can write that, but if I were to advise somebody, I would say that don't do that. Don't make a committee. Committees don't make decisions.
Do you see people making advanced directives in your practice like so far, or?
So it's just beginning. No? So earlier I used to give them the forms, explain to them what they were, and then, well, then I would say just talk about it. But now that with a notary, this is barely, how long ago? This is barely not even 1 month that it has happened. Now,
Sir, at present, it doesn't have to be signed by the magistrate, sir?
No, finished, that's gone.
Yeah, I mean, just only the
That's what
notary.
Supreme Court said it's now only a notary. That's why it's now become so much simpler. We expect it to happen. We think that this is a job for people who are trained in palliative care, because if you look at it, think of it as a kind of a vaccination. It's a preventive process. Like vaccination is the job of the pediatricians. I think advanced is the job of palliative care specialists.
Does it have? Does the advanced directive has any column or anything for the organ donation thing also?
As of now, not, because we think that when you come into organ donation, then the donor has to fulfill very specific criteria of brain death.
Right.
So that raises a separate issue. What happens if the person is badly damaged, does not want to survive, but is not brain dead? Now, that's something that we call donation after cardiac death. It's something that is possible in most Western countries, but for us, that is probably the next step that we have to work towards establishing.
Okay.
So I think we will wind up the session.
You run out of
There was a lot of discussion. So thank you, Dr. Roop, for a very wonderful session and answering a lot of questions also. And thank you, Dr. Ashok Matthew, and everybody who attended the session. Thank you. Shripriya.
Thank you everyone for joining in, and thank you, Dr. Roop, for spending those extra 25 minutes for us. Thank you so much. And I believe that everyone would now agree that he is one of the most apt persons to talk to us regarding end of life care. So thank you everyone for joining. Only 2 sessions left. This is Shripriya along with Dr. Roop Gursahani and Dr. Sunil Kumar and Mr. Anup signing off from the Tips Ecoha. See you in the next session. Till then, everyone take care. Bye-bye.
Bye. Good night.